First of all, good morning, good evening, and good afternoon to all our respected speaker, audience, chairs, and discussion. This is the this month series of ACNS Fujita Health University Bantane IVR web seminar. We are fortunate to have Professor Daijong from Jiao University School of Medicine, Shanghai, China, to chair our session together with Professor Yoko. We have two distinguished discussion for today. Professor Nakoya Kuwayama, who is a Deputy Administrator of the Hospital Director, Neurovascular Center, Toyoma Red Cross Hospital in Japan, and also Professor Yao Chi-Zhu, who is a Professor of Interventional Radiology from Shanghai Six People Hospital affiliated to Shanghai Jiao University School of Medicine, Shanghai, China. And our two speakers for today is our distinguished Professor Bing Zhao, who is a Associate Professor of Neurosurgery from Renji Hospital School of Medicine, Shanghai Jiao University, Shanghai. And also Professor Akioka, who is an Assistant Professor of Neurosurgery from Faculty Medicine, University of Toyoma, Japan. And without further ado, I would like to call upon Professor
Kuwayama. Prof. Sensei has joined us.
Oh, okay. So wait.
Opening remarks from Sensei.
Okay, probably, yes. Probably we'll hear opening remark from Professor Kuwayama first, followed by Professor Yoko. Professor Kuwayama.
This is Professor Kuwayama. I'm very happy to be here with you all, and I am looking forward to listening to the outstanding lectures today. Thank you.
Thank you, Prof.
Thank you, everyone. Thank you very much for joining today's Bantane webinar. I think the endovascular treatment is remarkable, advancing in the day by day, and that is a kind of the very ideal treatment for the patient who wish to have a very less invasive treatment. And that means is I think that today's two talks is very, very I think attractive maybe, I think. So let's start. Thank you so much.
Yeah, thank you, Professor Kato. Also, would like to hear from Professor Daijong for your short remarks, Professor.
Nice to meet all of you. Today, I think I am very glad I can learn more from this webinar. Thanks.
Thank you, Professor. So I will pass the session to Professor Daijong again to call upon our speaker to start their lecture. Professor.
So the first speaker will from our center, Professor Bing Zhao. His topic is the safety and efficacy of stent-assisted coiling for acute wide-necked ruptured cerebral aneurysm from retrospective to prospective study. Welcome.
Okay, thank you very much. Could I share my screen?
Yes.
Okay. Can you see it?
Yes.
Okay, it's good honor to be here to present our research program. This is the studies we have done. So I would like to share this the safety and efficacy of stent-assisted coiling of ruptured aneurysms from our retrospective and prospective studies. That I from China's Renji Hospital on behalf of the Safe Group. From the case, a 61 years old male with history hypertension for 10 years. He presented with headache, GCS 15, WFS grade 1. The CT scan showed that is some hemorrhage. The CT showed that is the ACNS segment aneurysms from after local hospital, outside of our hospital, he transferred to our hospital. We performed the digital subdural angiography. We found this aneurysm, the size is 6.5 millimeters. Next size is 3.6. So how to treat? For emergency, this patient presented with the wide neck aneurysms. We can do surgical clipping. These are the options. If we do with the endovascular treatment, I think maybe this wide neck will be needed as adjunctive embolization is needed. Like micro catheters or micro wire or balloon-assisted coiling techniques we need. We also can do treat with the stent-assisted coiling, like this. The screen showed us we put the stent micro catheters first, and then put the embolizations micro catheters put the inside of the dome. This is a procedures process. This is immediately angiography we showed completely occlusions remained grade 1. That's the case from PCOM aneurysms. This is complex. We put the Stent-assisted coiling, use the LVs. We also can protect the fetus PCOM. The immediately angiography showed is grade 1. But this, unfortunately, we also meet some patients. If we do Stent-assisted coiling for ruptured complex MC aneurysms, is some people mostly we can succeed, but unfortunately, this patient presented with ischemic complications after the procedures for 2 hours. This is ischemia here. Even though we can immediately angiography show complete occlusion and it's a good blood flow after the procedure, but this patient with ischemic stroke. My question is Stent-assisted coiling, ruptured aneurysm, safety or efficacy. How to treat? Stents broaden the indication for endovascular treatment, wide neck aneurysms. If we can put some single coiling, but if wide neck, we use the balloon-assisted. But we also can use the stent-assisted coiling. We from the literature, so we can see decreased rates of the new recurrence of retreatment after Stent-assisted coiling. In 2016, we published these papers. We do endovascular coiling, wide neck bifurcation, aneurysms. We performed a systematic review and meta-analysis. We found that its long-term good outcome, good neurological outcome is 75%. Procedure-related morbidity, mortality is 3.6. Maybe it's safe, but then we found this literature, so we only almost all this aneurysm and ruptured aneurysms. So how to treat the ruptured aneurysm? it's pathophysiology of the hemorrhage is complicated. We will have the uncertain constitutions like rebleedings, early brain injuries, delayed vasospasm, secondary injuries, hydrocephalus, high intracranial pressure. So this with this CT scans, we saw high facial greater. So it's ruptured aneurysms. It's different from the unruptured aneurysm. How we treat? We also published this papers in very early years. We found that the rebleedings in the early stages of the hemorrhage about 50% mortality rate per year's follow-up is 70%. So we can treat earlier using stent-assisted coiling. But we can see this is the literature with, even though we can do single coiling between the stent-assisted coiling, we can find that no differences in complications and outcomes. But we know this higher incidence hemorrhagic ischemic events with 70 days we treat. So around 2018, around the American guidelines, Korea guidelines for management subarachnoid hemorrhage. This is standing ruptured aneurysms with the increased incidence, morbidity, and mortality. So it's not recommended by the guidelines to treat. How to improve the safety and efficacy of the standing? I think we should. We can do it, but which patient can get the benefit from these procedures? Obviously, selected patients maybe less perioperative complications, thrombus or hemorrhage. Long-term outcomes, angiographic results, ultra earlier stenting could be better. Antiplatelet treatment regimens changes we can do. Different endovascular technology and materials is still changing. So we reviewed our data. We published the paper about 2016. We performed a single center retrospective analysis of ruptured aneurysms within 7 days of hemorrhage. This is a way versus we do 159 single coiling. Stent-assisted coiling is out 63. The patient we found that the incidence of intra procedures thrombus is a little bit high, is about 15.9%. This is the data before the 2013. So how to treat? So we try to perform the multi-center retrospective studies focused on the 24 hours we treat. So this is a low visualized profiles stents, iris stent. We included 101 patients were between January 2017, December 2017. We found that it's almost one half of patients treated with 24 hours. 88% patients presented with grade, good grade 1 to 3. The mean age is 58 years old. The mean size is about 5 millimeters. It's published the paper was published 2020. So we came from the data. This is the results. We found that intra procedures ruptures is a little bit low. It's 3%. Intra procedures thrombus formations is 4%. Most of the patients with post-procedure ischemia, early rebleeding is very low. We follow up the patient is completed occlusion is it's 96% is better than the literature published previously. We treat only the retreatment is very low. It's 2%. This long-term follow-up we can see. This is the angiography's results. We also find that the patient has favorable outcomes is about 89%. Oh, it's okay. We focus this preoperative embolic events occurred. It's 8.9%. Most of the location from MC PCOM aneurysms. We try to find how many patients, which patients occurs. This is thromboembolic complications. This is the follow-up we can see. This is the complications associated with the poor outcome. We performed analysis. We found that if we do the high grade, there will be high incidence of the thromboembolic complication in this study. We try to find the guidelines. These guidelines updated the guidelines for the treatment of ruptured cerebral aneurysms. This is China's guidelines. It is 2023's American guidelines. The guidelines is also changing. Stent-assisted coiling is reasonable to reduce the risk of rebleed. Wide neck aneurysms are not amenable to clubbing or primary coilings. We do assisted coiling, but there is lower evidence without high evidence. So we try to perform to multi-prospective registry studies. This is a patient enrolled from September 2020 and the finals enrolled patient is during the 2023. This study protocol was published BMC Neurology in 2022. We focused, this is studies, we selected the patients. We excluded the patients. If the patient with a hematoma more than 20 millimeters, we excluded. If we only included the most patients with good grade and wide neck, also similar like the previous studies. This study designs with standard treatment protocols, the choice standard coil deployment techniques was performed individually. EVD was used patient if acute hydrocephalus. This is antiplatelet regimens, the loading dose, Zhao's antiplatelet treatment consistence. 300 milligram clopidogrel and the 300 aspirins for 2 hours. But we have others antiplatelet regimens. We can use intravenous teriflunomide over 3 minutes and maintains more than 20 hours. This we focused on the thromboembolic complication within 30 days after treatment. The symptom outcomes, hemorrhagic complications and aneurysm recurrence, safety outcomes, favorable outcome, and death. This is baseline characteristics. We treated the 315 patients, but more small number of patients was follow up, lost the follow up. We also included in our study. This study was published last month in June. We included the 278 patients. The median age was 57 years. Most of the common aneurysm is PCOM aneurysm segment. About anterior communicating arteries aneurysm about one third. We treated most of the patients. We treated is 24 hours after the presentations. We use the stent. Most of the stent we use the uniform stent. Also followed by the enterprise. We use the RV stent, Leo stent, and the Sertal stent, others. We found that thrombectomy and bectomy complications, it's 11.5%, including intra-procedures, about 3%. The post-ischemic is 80%. We can see that, but with the secondary outcome, the hemorrhagic complication, was 4.7%. We can see this intraoperative hemorrhage is very low. It's 1.4%. Also, we can post-operative hemorrhage, EVD related hemorrhage, aneurysm rebleeding is very low. This is the follow-ups we do outcome and angiography results. At the last follow-up, we found that at discharge patient with 77% have good outcome. At follow-up, I was almost 90% have a good outcome. No mortality rate is 2.9%, aneurysm recurrence only is 7.2%. So we summarize our studies. The feasibility of the Stent-assisted coiling with high occlusion rate, reducing aneurysm rebleeding, is consistent with the current guidelines. We also find that intraoperative complications has increasingly become low over the years, compared with about 10 years studies data shows increasing lower. Ischemic complication is still an independent risk factors for poor outcomes in patients. So particularly, we found this post-operative ischemic stroke is main concern related with the Stent-assisted coiling for ruptured aneurysms. If we try to find how to prepare antiplatelet therapies to reduce ischemic stroke, but we didn't find the good options. This is antiplatelet therapies regimens is still needed to further studies to reduce the post-operative ischemic stroke. I think if we can reduce the post-operative ischemic stroke, maybe this patient will improve the most patient outcome. So thank you so much. Thank you for your attention.
Thank you, Professor, for nice talk. We start with our first discussion. Probably we hear comment from Professor Kuwayama, Professor.
Okay, thank you, Professor Zhao. Congratulations for your successful trial for the patient of acutely subarachnoid hemorrhage patients with the stent placement. And I would like to ask you, is there any difference between the result and the kind of stents you used? I heard you used several kinds of stents, right?
Yeah.
Leo or Elvis, or did you use Atlas? Only
Yes, uniform analysis. Yeah.
yes. Oh, okay.
Yeah.
It is.
So most patients are treated with analysis,
Mhm.
uniform.
And I think the metal amount is different from each other. Maybe Elvis or Leo is much metal rates. So I suspect there are some differences between the result of between the clinical result and the kinds of stents, intracranial stents.
Yeah, I totally agree with you. This we use the two types. Basically, is breeder stands and laser cut stands. This kind of stands enterprise and uniform antlers most often used. Probably there's a different kind of stands influence the results. So our graduate students will perform the post hoc analysis to compare different stands with different outcomes. But this will be coming. We can see the results later.
Okay. And
Thank you so much.
one more question.
Okay.
Did you evaluate the patient's coagulating function, like verify now, before treatment?
Neurological functions.
No. Platelet aggravation function. You know, verify now. It's a test for the platelet coagulation function.
Oh yeah, I know. Yeah. And this is only registry studies, but we found that we included 7 centers, but only is 3 centers performed antiplatelet functions we treat. But yeah, but only but 4 centers didn't use it. I think this is the only routine practice from the different centers. We not required. Every center should be required antiplatelet functions test. This main concern that is time-consuming to use antiplatelet function testing if we treat emergency. Most of the patients are treated with 24 hours after the hemorrhage. If like a different function test need more time to prepare and antiplatelet. So it's different. It's different way. Could it be if we do antiplatelet function test, will improve will reduce post-operative ischemic shock? We will try, but it could be we can change the different, Plavix, maybe high resistance of the antiplatelet, Plavix.
Okay.
So
I just ask you because 25% of population in Japan, 25% of people are poor or non-responder for the clopidogrel. Now we think about using a Presgrel instead of clopidogrel. There is very few people, very few non-responder or low responder for the Presgrel compared with the clopidogrel.
Yeah, I totally agree with you. But it's different policies to use.
Do you have any chance to use Procreate in China?
Not used often.
Not yet. Okay. Thank you very much. Okay.
Mhm.
Thank you.
Thank you.
Any question from Professor Zhu Yuanzhi?
Yes, thank you, Dr. Zhao, for your lecture. Very impressive lectures. I have only one small question about for the ruptured complicated aneurysm, such as a very large or giant aneurysm, maybe the recurrence rate after our first stage treatment will be very high. So in this circumstance, what kind of stent type will you prefer? The brand stent or the such as Leo, Ares, or the laser cutting stent such as Neurophone Easy or Atlas, which kind of which is of choice? Thanks.
It's a very good question. So we different stent probably influence the results of the complications. And just now we can tell from our data to make sure which stent we can use better. But if we treat, I think it's a retrospective study in our multi-centers show that LV stent is it's probably it's better, but it's a little bit have a high incidence ischemic complications probably. If we treat
yeah, if we will consider FD insertion at the second stage, what kind of stent will you choose?
If we can do pipeline probably. Prof.
At the first stage, or if at the second stage, in the ruptured aneurysm, maybe most doctors will not choose FD for at the acute stage, right? If you will consider FD at the second stage after the bleeding, will you choose Ares more than Neurophone Easy or Atlas?
It's different procedure from the techniques, the staged techniques. We can treat wide neck. We can try to kill the bleeding, and then do Stent-assisted coiling after the patient safety. You can do 1 month or 3 months. We do Stent-assisted coiling, like you maybe mentioned.
Okay, thank you.
Thanks.
Thank you, Professor. We also open to the other audiences. Whoever have question can raise your hand and ask question. Probably one question from me, Professor. You have shown in your study that the endovascular or stent-assisted coiling can be done within 24 hours of ruptured. Although so, the current guideline have never mentioned the time. And as you know that for surgical clipping, we always do as soon as possible. So in your opinion, should now endovascular procedure for ruptured aneurysm be considered to be done early with just a loading dose of double antiplatelet as you show in your study, or should they depends on the center? Because current most center they wait for 5 days. 5 days for open surgery is too long. So what's your opinion? Thank you, Professor.
Thank you. I agree with you.
So do you recommend to treat immediately for endovascular also for ruptured cases, Professor?
Yeah, I think it's a different position we treat. We treat earlier. We found that probably we can treat earlier, there will be benefit for the patient. Why? If they treated 3 days or 4 days, there will be high vasospasms period appears is uncertain considerations cause the patient with poor outcome. So we can see this our data is from about more than 80% treated very early as within 24 hours after hemorrhage.
Probably one more question, Professor. In a ruptured case with hydrocephalus, in your center, would you prefer to put external ventricular drain or a lumbar drain? And which one will you do first? Will you put the external, if you put the external ventricular drain, will you put the drain before the endovascular or after the endovascular? Thank you.
Yeah, it's a very good question. So we do EVD first. Oh, sorry, I'm sorry. We can do clipping the we can assist the coiling completed to make sure complete occlusion. Then we do second the EVD. Lumbar drainage, if we continue a long time, we can do a lumbar drainage to improve the submarine hemorrhage removal.
Thank you. Probably we pass back to the chair, Professor Daijong, for your comment.
Yes. I think the stent-assisted coiling for the acute ruptured aneurysm, the balance between the rebleeding and the thromboembolic complication is we care for. So I have one more question is we will use the antiplatelet drug for the different type stent, Professor Zhao. If you use Airways or Enterprise or Atlas, your antiplatelet drug will different.
I can say the same procedures, antiplatelet procedures. Most of the centers also with our data, we found that most of the patients treated with intravenous paraffins, I think maybe it's helpful for these patients for early, very early treatment. You don't use Dural's antiplatelets, Plavix, and aspirins. We do the thing.
Yep.
Any concluding remark from you, Professor Daijong, or we can move to the second speaker? Okay, if there's no further question, we thank Professor Bing Zhao for excellent lecture, and we hope to see more such study, probably involve other centers, and we can collaborate with your study in the future. Let me invite Professor Daijong again to introduce our second speaker, Professor. I think Professor Daijong line is disconnected, probably. You give me an honor to call upon Professor Akioka, who is an assistant professor at of neurosurgery and faculty medicine of University of Toyama, Japan, who will present to us on endovascular treatment of the Dural AV fistula. Let us welcome Professor.
Thank you. I'm sharing my slide. It's an honor to have you join this webinar, but please know that it is basic and educational. So in this presentation, I would like to talk about endovascular treatment of dural AVF, focusing on basic concepts of dural AVF treatment and the current trend in Japan. Sorry. I'm sorry. Sorry, can I reboot my sorry.
I'm gonna restart.
My computer is stuck now.
Only PowerPoint is stuck.
So
We can see you. We can see you. Okay, Professor Liu, can I talk something?
Yes, yes, please, Professor.
So, to tell the present status in Japan, the Japanese government does not allow us to use stents, intracranial stents, for the patients of acute subarachnoid hemorrhage. And usually we use balloon-assisted technique to embolize the ruptured aneurysms in acute stage. And if it's difficult, we sometimes do just bleb embolization to leave the aneurysm neck open, and then retreat the patient afterward, maybe 2 weeks or 3 weeks later. Then we can use intracranial stents with the dual antiplatelet therapy. So we are not used to using stents in acute stage for the acute subarachnoid hemorrhage patients. And balloon assist technique is one of the potential modality to treat the ruptured aneurysm. I think so.
Yeah, thank you, Professor.
So yeah, and if we use stent, we usually test the patient by Verify Now to know the platelet coagulation function before treatment. And we can know PLU and ALU for the clopidogrel and aspirin. And if the clopidogrel effect is very, very low, we use now prasugrel instead of clopidogrel. Prasugrel is a very, very strong antiplatelet agent, and it has very few patients who are non-responder or poor responder, and it's a very effective agent.
May I know how about using flow disruptor like a web in ruptured cases?
We can use web. We can use web for the acute ruptured aneurysm, but we cannot use, still not used in a flow diverter like a pipeline. But we just can only use web.
Mm.
Mm.
Which one would you prefer, Professor, for ruptured case white neck in current practice in Japan?
What do you mean? Which
Which device to use in ruptured
device?
white neck? Yes.
Balloon assisted coiling. Balloon
Okay.
assisted coiling. Yeah.
Yeah. Professor Akioka is here. Right? You may
Okay.
try again.
Very sorry.
Three
I'm
times.
come back now. So in this presentation, I would like to talk about the basic concept of dural AVF treatment and current trend in Japan. The treatment of dural AVF depends on the severity of symptoms in its angiographic features and the associated risk of intracranial hemorrhage. Aggressive types, especially those with cortical venous reflux or RLVD, should be treated as a carry high risk of intracranial bleeding or neurological deterioration. In aggressive type regions, the annual rate of ICH is around 7 to 8%. The combined risk of the ICH and non-hemorrhagic neurological deficit is approximately 15%. Cases that present with ICH have a high risk of the bleeding, rebleeding, according to the meta-analysis, and the rebleeding rate is high as 46%. This makes this region even more dangerous than AVMs. Now, I would like to explain the basic concept of dural fistula treatment using the schematic diagram. The AV shunt is located within the dural matter itself, where the direct connection can be observed between the dural artery and dural vein. The goal of treatment is to occlude this AV shunt within the dura. Let's consider the case of TAE. Is proximal occlusion of the feeding artery effective? The answer is no. Even if the occluded artery proximally, blood flow will still reach the shunt to the collateral circulation from the other arteries. Even if each individual feeding artery is occluded, recurrence is likely unless the shunt itself is completely closed. Injection of liquid embolic agent from the proximal artery should be avoided. The embolic material may migrate into the basal bone or even into the ICA or VA through the dangerous anastomosis. A TA should be performed as close to the shunt as possible. However, it is essential that there are no basal bone or dangerous anastomosis near the feeding artery. For these reasons, lesions in the cavernous sinus and anterocondylar conference are generally not suitable for TA. Occlusion of the dural vein involved in the shunt is performed using an embolic agent. Packing within the affected sinus can also help occlude the shunt that supplies by other feeding arteries. In addition, any refluxing cortical vein should essentially occluded. The introduction of onyx has greatly facilitated this type of embolization. Next, let's consider the case of TVE. Should we occlude the refluxing vein, such as a vein of Labe in the sigmoid region or superophthalmic vein in the cavernous sinus region? In other words, should we perform outflow occlusion? If there are other outflow pathways, treatment may be inadequate, and the shunt can persist or new cortical venous reflux may develop. Outflow occlusion is often effective in the non-sinus type regions with simple venous drainage patterns, such as those located as anterior skull base or tentrum. So the basic concept is TV is achieve film embolization of the affected sinus as close to the shunt as possible. Veins are not part of the normal venous drainage can be embolized, and any refluxing cortical vein should be occluded. Once there is no remaining outflow, the intradural shunt will thrombose. If a vein shows a progressive or antegrade drainage, it is preferable to preserve it whenever possible. A branch from ACA typically supplies cranial nerves near the cavernous sinus and skull base foramina. TA is contraindicated in region with a risk of occluding the neural supply branches. Onyx TA is effective for both non-sinus type and sinus type dural ABF, particularly those with isolated sinus. In recent years, treatment trend of dural ABF in Japan, particularly for the cavernous sinus regions, has a shift from whole sinus packing to target embolization. The localization of the shunted pouch is the cavernous sinus dural ABF has been previously reported, and it is most commonly found in the posterior region, either posterior medial or posterior lateral. Now we present a case involving cavernous sinus region. A 90-year-old woman presented with a venous infarction and intercerebral hemorrhage. Right external carotid angiography revealed AV shunt in the right cavernous sinus with reflux into the superficial middle cerebral vein. 3D rotational angiography with MIP image is useful for identifying the exact location of the shunt. Important point of treatment, understanding dangerous drainage, identifying shunted pouch, and catheter stabilization for the target embolization. TVE was performed via left IPS and entering the right cavernous sinus through the cavernous sinus, guiding the microcatheter first to the orifice of SMCB. Microangiography showed a retrograde reflux of the SMCB clearly. The embolization is first performed at the SMCB to occlude dangerous drainage. The reflux is disappear. The next microcatheter is advanced into the shunted pouch where the shunt is concentrated. In this case, the shunt is concentrated on the superior part of cavernous sinus, and coiling embolization is performed in this area. The shunts were reduced, but the shunt were relatively extensive and remained at the medial side. When guiding the microcatheter to that side, as you can see, we looped microcatheter to stabilize the catheter. By tight packing at the remaining shunted point, the shunt was completely occluded. Here is the next case. In this case, AV shunt not localized to the single shunted pouch, but diffusely distributed. There is also retrograde venous drainage into the SMCB and deep veins. When considering the anatomical structure of the cavernous sinus, the report by Mitsuhashi is quite informative. By comparing their schematic diagram with a source image, a rotational angiography image from this case, we identified the AV shunt located at the sinus of dorsum cella, number 1, 2, and intermediate axis of the cavernous sinus, number 3, and from the medial axis to the sinus of the lesser sphenoidal wing, SLSW, number 4. And based on these findings, we decided to perform target embolization for each individual shunt site. We first performed the coil embolization for the shunt located in the sinus of dorsum sella. We navigated microcatheter in each of the two shunted pouch and performed compact embolization at both sites. Next, we performed the embolization of the shunt located on intermediate axis of the cavernous sinus. We performed coil embolization for this pouch. However, the shunt persisted and retrograde flow into the SMCB remained. Therefore, to eliminate the retrograde flow into the SMCB, we decided to embolize the site where the SMCB drains into the cavernous sinus. Venography demonstrated retrograde flow into the SMCB and deep veins. Coil embolization successfully eliminated these venous refluxes. Finally, we decided to occlude the remaining shunt located at the SLSW. We advanced the microcatheter in the SLSW, performed the venography to confirm the contrast outflow, and then proceed the coil embolization within the sinus. The distribution of the coil is shown on the left figure, and geography confirmed a subtotal occlusion of the shunt. As demonstrated in this case, even in a patient with a diffuse shunting, careful anatomical evaluation allows for the effective treatment without the need for the whole sinus blocking. Another recent trend in the treatment of dural AVF in Japan is a shift in the management of transverse sigmoid sinus dural AVF from coil TV to Onyx TAE. In Japan, Onyx was approved for insurance coverage in 2018, and since then, its use has rapidly expanded. The way we inject Onyx has also changed in recent years. With the introduction of the deflector microcatheter, which is a very thin, TAE techniques have also changed. In the early days of Onyx use, we often use a septal balloon microcatheter to stop the reflux of Onyx, and they usually perform the embolization through the occipital artery for safety. But with a deflector, Onyx can be injected very close to the shunt, which helps it reach the affected sinus more directly and make embolization easier and more effective. Deflector is designed to minimize friction and maximize reachability to distal vessels. In the past, only palliative TAE was possible for the patients with patent sinuses. But now we can perform TAE with transvenous balloon-assisted protection of the sinus. In Japan, the Shoryu balloon catheter is commonly used, and we also use a Starling balloon catheter. This case presented with a popular edema was classified as Boden type 1. Angiography revealed the left transverse sigmoid dural AVF without cortical venous reflux. There are diffuse arterial feeders and a high flow shunt with a patent sinus and retrograde drainage into SSS. Left internal catheter angiography demonstrated obstruction of antegrade flow in SSS and cerebral venous congestion. In this case, it is important to allow the sufficient Onyx penetration into the shunted pouch at the TS junction. When we measure OA and MMA separately, it is clear that the shunt flow from the OA is much greater. So in this case, which artery would you choose for embolization? We still perform embolization via MMA. In this case, sinus protection was achieved using a Starling balloon. TA was performed via the posterior convective branch of the MMA using diffractor nano. And the onyx reached to the sinus and penetrated between the balloon and the sinus wall, and retrogradely filled the other sinuses, including the OA and STA. The shunt was almost completely occluded, and the sinus was preserved. A follow-up internal carotid angiography showed improvement of SSF's drainage, and papillary edema also resolved. Finally, in recent years, careful anatomical evaluation enable selective embolization of the shunt points, avoiding the unnecessary sinus occlusion. Advancements in microcatheter technology such as a diffractor have further enhanced the safety and effectiveness of TA, even in complex or high flow cases. Thank you for your attention.
Thank you, Professor Akioka. Let us invite our discussion. Professor Zhu, question from you, Professor, or comment?
Okay, thank you. Thank you for Akioka. A lot of impressive cases. I have three small questions. The first one is that for the cavernous sinus DFF, I learned that the target embolization was the most effective. But how to judge the fistula to the venous, the site may be very, very difficult. Do you have any tips to judge the location? The second question is that where you leave two or more microcasters in the venous for one for maybe for coin embolization and the other maybe for onyx injection, because after the coiling embolization, one by one, the microcaster will change its place. Maybe the injection of onyx will become difficult. So where you leave two microcasters in the venous. And the third question may be that how you judge to choose the coil and the onyx. A few coils and plus onyx, or more coils plus a little onyx, because we know that DMSO may be cause some nervous toxic to the nerve. So what is your choice?
Thank you for your question. The answer for the first question to the identifying the shunted pouch in the cavernous sinus, we use 3D notation angiography source image, and or cone beam CT from the ECA or acinopharyngeal artery or something. So we evaluated the source image of the rotation angiography. So the high contrasted area is maybe shunted pouch.
So where you to do the microcaster angiography through the artery to make sure if the fistula was accurate to locate the position through the microcaster from artery.
Sometimes I after introduce the microcatheter, and we perform the cone beam CT or something, and identify the tip of microcatheter locations.
Yeah, understood.
But yeah. And to second question, coil onyx, you mean?
Will you leave two microcasters in the venous to one for coiling and one for onyx injection? Will you do so?
Transvenous or transarterial?
Venous?
Transvenous.
Yeah.
Okay. It's very good procedure. Lap packing with the coiling,
Yes.
and injection the onyx intravenously from onyx TV. You mean onyx TV? Onyx TA and
Onyx TV
TV.
use two casters in the venous. Yeah.
In the venous. Okay. I don't have any experience intravenous onyx injection, but I hear that method is very good. Yeah, but I have no experience there.
Yeah,
Okay.
I understood. Yeah.
Okay, Dr. Akioka, I'm Kuwayama from same university. I have some experience. And you can put several coils in the sinus and then put onyx in the sinus itself. And it's a very, very economic and effective way to occlude the involved sinus. But sometimes if you put the microcatheter in the deep caster of onyx, it will be very, very difficult to pull the microcatheter from the cast of the onyx. So at first, you should start with the very, very distal part to embolize by onyx, and then pulling microcatheter, and packing the sinus one by one from the distal side to the proximal side. So, and in order to do this way, you should enter to the involved onyx from the proximal side. If you enter the involved sinus from the distal side, we usually put a very strong distal 中間カテーテルなんだっけ
Distal access catheter.
Distal access catheter to the very, very in front of the involved sinus. Then you can pull the microcatheter very strongly into the duct. This is the way of transvenous onyx injection into the direct sinus injection.
Do you have any other microcasters such as Apollo?
No.
No, we have no
Japan?
Apollo.
We
have
if
no
you have
detachable
Apollo,
catheter.
Yeah, this issue will be solved. Yeah.
We should have, but it has not come yet.
Yes.
Okay, thank you.
Thank you.
Thank you.
Okay. Question, Professor Kuwayama, you have any question? Or no? Because
I already. Anyway, Dr. Akioka talked Defricta. Defricta is a Japan-made very powerful microcatheter, and I don't think this is available in foreign countries, right?
Maybe North America is available now, I think.
If you have Defricta, please use it. It's a very, very effective catheter to put the onyx from the arterial side. It's a very, very tiny catheter in diameter in the distal tip. Thank you.
Thank you.
Probably one question from me, Professor. In case there is a low grade fistula without reflux, and at the same time there is a thrombosis, sinus thrombosis, is it fair to treat the thrombosis and hope that the fistula will resolve by itself, or you treat both? Thank you.
You mean anticoagulate therapy and
Yeah, by
You mean-
giving anticoagulant for the thrombosis, to treat
Yeah.
the thrombosis first and wait for the resolution of the AVF, or you will treat both together? Thank you.
Yeah, I have experience for the SSS shunt, SSS dural AVF caused by the sinus thrombosis, but we treat by the endovascularly and to the shunt, and after that, we the patient take the DOAC long time, and this is a for the recurrence of the dural AVF, prevent for the recurrence of dural AVF, the patient has taken the DOAC now.
For the venous access, would you face the problem in the thrombosinus for the venous access to the fistula? To treat the fistula?
Yeah.
In case of thrombosis?
Dr. Akioka, thrombosis means sinus occlusion, not
Yes,
acute thrombosis. Sinus occlusion.
Transfusion.
How do you get into the involved sinus through the occluded sinus?
Transvenously.
Right.
Yeah, I understand. And we penetrate the occluded sinus by the guide wire, micro guide wire and echelon microcatheter. Very tough catheter and echelon 14. We use the microcatheter, so we can penetrate the occluded sinus. For example, the transverse or IPS for the cavernous sinus.
Thank you, Professor.
Yeah.
Any comment from Professor Daijong?
Yeah. I think DAF is a very complex type of cerebrovascular disease, and its treatment is also very challenging. Endovascular treatment, of course, I think is the first choice for the DAVF. So my question is, how do you think about the radiosurgery or microsurgery for the DAVF? Thanks.
Thank you for question. I prefer the endovascular or surgical treatment, but it's a refractory lesion. For example, the temporal dural for Tokyo dural. So we choose a radio surgery, cyber knife or gamma knife.
Yeah.
Is
Yeah.
to the temporal Tokyo lesion.
Yeah.
But we do not choose SRS only for the cavernous or transfer something. We do not choose the SRS.
Yeah. I see.
Thank you.
Yeah, thanks.
So stereotactic radiosurgery should be thought as a last choice for us.
Yeah.
You should go with your catheter as much as you can.
Yeah, I agree.
Thank you.
And sometimes open surgery is very effective, like for the lesion of the anterocranial fossa or type 3 or 4. dural AV fistula. Direct clipping of the involved vein is very, very effective and economical and very short.
Yeah.
Mm.
Yeah. Thanks.
Thank you.
Okay.
Probably one more question, Professor. How about spinal dural AV fistula? Which are you think the most effective treatment modality?
Thank you. In our institution, 50-50 and vascular and surgery. We perform the provocative test from the feeding artery for microcatheter. If it is positive, we choose surgery. But it is negative, we do the embolization.
I just want to find out from you, Professor. For spinal AV fistula, do you think that you need a hybrid OR to perform? Because I've seen one case where it's from certain level of feeders, but subsequently after clipping of the communication, you can see other feeders in angio OR. So do you think that it's common to have such occurrence, and you think the best to use hybrid OR for cases like this?
Thank you. A hybrid OR is the best choice, but we have a hybrid OR, but we do the surgical trapping only the C-arm angiography, intraoperative angiography. But when we can use hybrid OR, so we use hybrid OR. It is the best choice. It is the best. Yeah, I think.
Thank you. If the audiences have any question, you may raise your hand and ask. Probably we get a comment from Professor Yokokato.
Well, maybe I think some of them from my department, the current fellow, Dr. Wei. You may ask some question to excellent speakers. Or you may ask in Chinese. Wait, is it? Dr. Wei?
Oh,
Yes, please.
Professor. Hello, Professor.
Hi.
Because I don't perform this cases before, so so I don't have experience in treatment, in the vascular treatment for DVF. So I I can't got a good question now. I'm just studying.
Okay,
It's a very good anatomy and a very good technique skills. Professor have showed us. I study very much. Thank you.
Thank you very much. So Abhishek.
Thank you.
Okay.
Am I visible?
Raj.
Can I?
Yes.
Yeah. So good evening, everyone. I'm Dr. Rajkumar. I'm from India. I'm currently a fellow in Fujita University. So congratulations. It's a very wonderful presentation. According to me, the complex and most difficult endovascular intervention in neurosurgery is dural AVF. And it's very difficult, and we have to plan accordingly, and we have to calculate how deep we have to go, where we have to start the onyx injection. And it's a wonderful presentation. And even in Fujita, I have seen coil embolization. Mostly we do onyx embolization back in India, but coil embolization I have seen. And transvenous also we have approached. Transvenous and transarterial combined will be a good approach for embolization. And all my doubts were asked by Dr. Leo, so I have no doubts at present. And it's a wonderful presentation. Thank you.
Thank you.
Thanks, Abhishek.
It was a wonderful presentation. Thank you for such a wonderful presentation. I've learned a lot today. Thank you.
Thank you very much.
Thank you very
I
much.
think maybe they do not have enough experiences about the dural AVF and so the difficult cases. But they learn a lot. Thank you so much from to the giant endovascular surgeon, I think, and also a great comment from Koyama Sensei and also the Dr. Tsu. Thank you so much. And my good friend of Dr. Dai, thank you very much for organizing this wonderful webinar with Dr. Liu. I think endovascular treatment is maybe the replace the open surgery, I think, in future. Because I never seen the bypass surgery. Of course, someone said the bypass surgery is remaining in future even. But I think in Europe, they seldom to do the bypass surgery. So I think maybe in future is maybe some medication for increasing of the vascularity instead of the bypass surgery. So we learned a lot. So the immediately disappear the symptoms such as tinnitus with embolization for the dural AVF. I think that is amazing treatment. Congratulations. Thank you very much, Akioka Sensei. And also the Dr. Zhao, I learned a lot from your talk. I think recently the institute very seldom to see the coiling because of the many web cases. So I think maybe is maybe a different opinion from Koyama Sensei. I think in future, I think web is a first line for treatment of the, especially the aneurysm cases. I think. そうですか、小山先生。Maybe in a one or
Maybe.
maybe in 1 or 2 years. Still, in Japan we have a very limited the web type, but in future the very smaller one, maybe the shape is a different one, it will be coming up soon, I think. Then more variety the treatment for the aneurysms. I hope. I am the open surgeon, but I expect a lot from the endovascular treatment. Thank you very much for today's webinar. Thank you so much, Dr. Liu.
Thank you, Professor. Any last comment from you, Professor Daijo?
Yeah, I think thanks. I'm glad today, very glad that can see my tutor, Professor Kato, online again. So I hope we can have meet offline. I think in the future we
Yeah.
can discuss face to face. I think it is very excellent. Thanks.
Yeah.
Thanks.
Thank you so much, Dr. Dai.
Thank you to Dr. Dai and Professor Kato, and also thank to our both speaker, Professor Zhao and Professor Akioka, and also our discussion, Professor Kuwayama and Professor Zhu. And we meet again next month. Thank you, everybody.
Thank you
Thanks.
very much. Thank you.
Bye bye.